Hello everyone and welcome back to Dr. Hill Medical Lecture. Today we will learn the first and foremost lesson, examination of surgical abdomen. By this lecture, students will be able to understand and apply the following key concepts. First, to analyze the definition surgical abdomen. Second is the ability to divide the abdomen and analyze its role in abdominal examination. A third one is analyze the 6 principles and 4 essential skills in surgical abdomen examination. The last one is to apply surgical abdomen term in clinical practice. To begin, we need to clarify what is meant by a surgical abdomen. So a surgical abdomen is a clinical term that varies in definition depending on the surgeon, but it is generally understood and applied into context. The first meaning is surgical abdomen refers to the 4 main lesions that typically necessitate emergency surgery or intervention. The first one is intra-abdominal inflammation. Here is localized lesions. This includes conditions such as appendicitis, necrotizing enterocolitis, microdiverticulitis, and intra-abdominal abscesses. The second one is peritonitis. Here is the diffuse inflammation. This occurs due to the perforation of a hollow viscous, which may result from various pathologies like ruptured appendicitis, perforated duodenal or gastric ulcers, perforated tumors, or traumatic rupture of a hollow viscous. A third is obstruction. This could involve mechanical intestinal obstruction, biliary obstruction, or vascular occlusion, such as mesenteric artery or abdominal aorta occlusion. The last one is intra-abdominal bleeding. This may be due to pathologies or trauma like a rupture aneurysm. The second meaning here of surgical abdomen refers to an initial diagnosis where the patient is indicated for hospitalization to undergo further observation or emergency intervention. So, usually, the patients present the painful symptom. This situation often arises when a diagnosis must be made really quickly, such as during periods of high patient volume, pandemics, or a wartime, where the need for urgent intervention outweighs the ability to perform a definitive diagnosis because of the lack of time and investigation. Next, in this slide, I will discuss the fundamentals of abdominal examination with a focus on both general abdominal assessment and surgical abdomen. Firstly, let's talk about the importance of abdominal divisions in surgical abdominal examination. So by dividing the abdomen into specific regions, we can accurately locate organs within the abdomen and identify the area of potential damage. This process helps us to orient ourselves toward the possible cause of the disease. Then guiding subsequent and most valuable investigations such as abdominal X-ray or ultrasound or CT scan. For instance, pain in the right lower quadrant often suggests acute appendicitis and need further abdominal ultrasonography, while sudden and severe pain in the epigastric region could suggest a duodenal perforation, prompting the need of an X-ray examination. Additionally, by localizing the onset of the symptoms to a specific quadrant and observing the progression of the symptoms from one quadrant to others, we gain valuable insight into the affected organs, the underlying cause, and the stage or severity of the disease. For example, if pain begins in the right iliac fossa and then spread to the hypogastric area, with tenderness and abdominal warding more pronounced in the right iliac fossa, this pattern strongly suggests peritonitis due to a ruptured appendicitis. Secondly, let's discuss how to divide the abdomen. And of course, we have to learn by heart the organs in every region. There are two primary methods. The first one is to divide the abdomen into 4 quadrants. This method is typically used when symptoms are spread over a larger area. The quadrants are defined by 2 lines, one horizontal line passing through the umbilicus and one vertical line connecting the sternum to the pubic symphysis. So the quadrants include the upper right quadrant, upper left quadrant, the lower right quadrant, and the lower left quadrant. The second is dividing the abdomen into 9 regions. So this method provides a more detailed localization, useful for identifying specific lesions and the exact organs involved. The abdomen is divided by 4 lines. 2 horizontal lines. One connects the lowest bony point of the rib cage. Usually here is the 10th, and the other connects the 2 anterior superior iliac spines here, and 2 vertical lines. These run through the middle of the clavicles and down through the middle of the inguinal ligament. So the 9 regions are as follows. The right hypochondrium, here the right hypochondrium region, and here the epigastric region, here the left hypochondrium region, and here the left flank, the left iliac lesions, the hypogastric region, the right iliac fossa, and the right lumbar region. And the last one is the umbilical region. You have to learn by your heart all the organs containing in 9 regions here. For example, in the right hypochondrium contains the right lobe of the liver, the gallbladder, a right colon, a right adrenal gland, and upper pole of the right kidney. The epigastric region include the left lobe of the liver, part of the anterior surface of the stomach, cochlea, pylorus of the stomach, the hepatogastric omentum, the duodenum, pancreas, the initial part of abdominal aorta, and the inferior vena cava. With the left hypochondrium contains the spleen, stomach, left colonic flexor, the tail of pancreas, left adrenal gland, and the upper pole of the left kidney. With the left flank or lumbar region include the descending colon, small intestine, and the left kidney. With the left iliac fossa contains the sigmoid colon, small intestine, left ovary. With the hypogastric or suprapubic region contains the greater omentum, small intestine, bladder, distal ureters, broad ligament, round ligament, fallopian tubes, and the uterine arteries and veins. In the right iliac fossa contains cecum, appendix, small intestine, and the right ovary. With the right flank includes the ascending colon, small intestine, and right kidney. And the last one, the umbilical region, contains the greater omentum, transverse colon, small intestine, mesenteric lymph nodes, bilateral ureters, abdominal aortas, and inferior vena cava. Continue in this line, we will learn how to examine the surgical abdomen. So the examination of a surgical abdomen generally involves several key skills, including history taking, physical examination, and interpretation of investigations. These are all crucial for detecting symptoms that can lead to the diagnosis of a surgical abdomen. Such symptoms can be functional, physical, or paraclinical and often indicate conditions like inflammation, obstruction, peritonitis, or intra-abdominal bleeding. So now we talk about medical history. We can recognize a surgical abdomen with a thorough medical history, and here are key aspects to consider. The first one is characteristics of the onset and the progress. The shorter the duration, the more severe and sudden the symptoms, the more likely you are dealing with a surgical abdomen. Remember for me. Rapid onset is a red flag. But how do we determine if the onset is rapid or sudden? So, a key indicator is the patient's ability to recall the exact moments when the first symptom appeared. The patients with a surgical abdomen often remember the precise time and situation when the pain or other symptoms began. For example, a patient might report experiencing severe pain in the epigastric region exactly at 11 o'clock, shortly after eating a meal or drug. This specific and vivid recollection of symptoms onset is characteristic of many acute abdominal conditions, making it important detail in the diagnostic process. Second, the location and characteristics. The location of pain and its characteristics should be analyzed together. Example, pain in the right iliac fossa had the characteristics of localized, dull, continuous, gradually increase, meaning the inflammation, suggesting appendicitis, unless the permanent or intermediate pain suggesting ileal inflammation. Otherwise, obstruction of the bowel will show us the intermediate pain, or when the pain is severe or permanent or continuous, suggesting twisting or strangulation of the bowel. or the patient complains the severe pain of an inguinal hernia or a lump, suggesting the strangulation hernia. Of course, we must ask other symptoms like vomit, constitution, or distension. Or the abdominal pain accompanied by a blood diarrhea, abdominal pain followed by a drop in blood pressure, or fever after abdominal pain. Also, symptoms are less or not adaptive with internal treatment. All these symptoms suggesting the surgical abdomen. Remember it. However, we have to remember all the symptoms must be in the dialectical relationship, maybe the relationship of time or cause and effect. Now we talk about the past history. When evaluating a patient for a surgical abdomen, it is crucial to explore their past medical history, as this can provide us valuable clues regarding the current condition. Key aspects to inquire about include previous abdominal surgery, the history of gastric or duodenal ulcers, and the third one is chronic conditions. For example, a history of abdominal surgery combined with recent intake of foods such as jackfruit, bamboo, crispy persimmons, or figs may suggest the possibility of intestinal obstruction. Adhesions from previous surgeries are common cause of such obstruction. Also, history of gastric or duodenal ulcers. Patients with a history of gastric or duodenal ulcers, especially those who use non-steroidal anti-inflammatory drugs we call NSAIDs, or patients who have been under significant stress or at a high risk for perforation of hollow organs. This history is crucial in assessing the potential for a surgical emergency. Or the conditions such as hypertension, diabetes, obesity, and atrial fibrillation are risk factors for mesenteric embolisms. These can lead to ischemia and necrosis of the bowel. Now we move to the main part of the lecture, a physical examination. So we have to master the principles of surgical abdominal examination. It is essential. Now we break it down into key steps. The first one is preparation. We have to ensure a proper environment. It means the patient should be examined in a well-lit room. If the patient is female, it is recommended to have 3 or more people in a room to ensure comfort and propriety. Talk about the patient positioning. The patient should lie in a comfortable position with relaxed muscles. Typically, both legs should be bent at a 45-degree angle between the thighs and legs. However, if the patient has paralysis or stiff knees of the hip or any joints, adjustments should be made accordingly. We have to accept it. Next, we have to expose the patient or the abdomen properly to ensure the abdomen is adequately exposed superiorly from the level of the 5th intercostal space to anteriorly superior iliac spine and upper border of the pubic bone inferiorly. How about the position of the doctor? The doctor should stand or sit on the patient's right side for the examination, but may change positions as needed to perform the examination effectively. Next, the communication. It is crucial to explain a step of the examination to the patient. Instruct them to inform you if they experience any pain during palpation or if they need to pause or stop the examination for any reason. Secondly, we talk about the systematic examination. So we should examine the patient from head to toe. We start examination from head and proceed systematically to the abdomen. So within the abdomen, begin with normal area and then move to the painful area, processing from superficial to deep palpation. Remember, always use gentle technique. Avoid starting with strong pressure. The third one is proper hand technique. Place your entire hand on the patient's abdomen and use your fingertips. Remember, use your fingertips to feel for any abnormalities. Remember, never use the word press. I recall the word palpation. And the fourth technique is observation of facial expression. So pay close attention to your patient's facial expressions during the examination. If patient grimaces, this indicates pain and the examination should be paused. And the fifth is comparison. Always compare and contrast both sides of abdomen and contrast and finding with normal area and with what is expected in healthy individuals. That helps us in identifying asymmetries or abnormalities. We talk about the last principles is to repeat, change hands and distract patient attention. In case of the examination is challenging or difficult, repeat the examination, change the patient position, switch your hands or distract the patient. Additionally, use paraclinical measures and conduct a systematic examination along with assessing other organs as needed to get a comprehensive diagnosis. Now, let's move on the 4 essential skills of surgical abdominal examination. The first one is inspection skill. During inspection, we carefully observe the abdomen for the following signs. Scar. The surgical scars may indicate previous abdominal surgery, which can suggest the possibility of intestinal obstruction or recurrence of prior diseases, for example, recurrence of cancer. Second, we look for abdominal distension. A distended abdomen may indicate the presence of dilated intestinal loops, often seen in cases of intestinal obstruction or volvulus. Additionally, severe distension accompanied by pain can be a sign of peritonitis. Snake crawling sign. So, the sign refers to the visible peristaltic waves moving across the abdomen, suggesting intestinal obstruction. The sign is particularly important in diagnosing mechanical obstructions. Next is abdominal muscle spasticity. Wadding is the involuntary tensing of the abdominal muscles in response to pain palpation, and it along with the reduced or absent mobility of abdomen during breathing, strongly suggests peritonitis. Next, we talk about lesions due to trauma. Look for any external signs of trauma, such as wounds, especially if they are associated with visible feces or digestive fluids. which may indicate perforation or severe injury to gastrointestinal tract. Next, we move to the palpation skill. Palpation is a critical component of the surgical abdomen examination, and it requires a systematic approach to accurately identify areas of concern. To begin with, we identify the painful area. In this approach, we locate the general area of pain for each anatomical subdivision. Consider common pathological lesions that might be present. For example, pain in the right iliac fossa often suggests appendicitis or cecal diverticulitis. Next, in palpation, we have to identify the pain point or tenderness. We can locate specific lesions by locating the pain point and tenderness. For instance, in the right lower quadrant, Marconi point is a classic indicator of acute appendicitis. However, it's important to note that in cases like cecal diverticulitis or cecal inflammation, a painful area is the right iliac fossa, but a tenderness or pain point might be more pronounced or higher than the Marconi point. The principle of determining pain points, here I show you. To identify the pain point, we have to base on fixed anatomical landmarks. The pain point is determined at the intersection of straight lines connecting two fixed anatomical landmarks. This precise method ensures that examination is both accurate and repeatable. Also, while palpating the abdomen, we have to determine the level of pain. As previously mentioned, a patient showing severe pain and reflexively pulling the doctor's hand away during superficial palpation indicates a higher level of inflammation and increases the suspicion of a surgical abdomen. Conversely, less pain during deep palpation may suggest a lower likelihood of surgical abdomen. Next, we talk about abdominal warding. It is crucial for all doctors, remember for me, especially abdominal surgical doctor, to thoroughly and accurately assess abdominal warding. So the presence of abdominal warding is a strong indicator of a surgical abdomen, with approximately 99% of cases requiring surgical intervention. Therefore, correctly determining abdominal warding is of utmost importance. Remember it for me. So, we have to identify and to differentiate from abdominal warding and from the abdominal muscles training. However, it is important to remember the absence of abdominal warding does not entirely rule out a surgical abdomen. Early in the disease process or in a specific population, such as the elderly or those with multiple pregnancies, there may be a loss of abdominal muscle tone, leading to a lack of warding even in a serious condition. Besides, when evaluating a patient with a hernia, palpation of a hernia mass is an essential step to determine whether the condition may require surgical intervention. It is painful hernial mass and irreducible hernial mass, which the hernia cannot be pushed back into the abdomen. Next, we talk about percussion skill. Percussion is less common in surgical abdominal exams compared to other techniques because it can cause additional pain to the patient, and its findings are only valuable when accompanied by other clinical symptoms. Its diagnostic utility is limited because the symptoms detectable by percussion tend to only become apparent when they are severe, clearly, or in the late stage of the condition. Next, we move to auscultation skills. Auscultation skill plays a key role in assessing various abdominal conditions, particularly when evaluating intestinal motility and vascular cells. This skill has diagnostic value in distinguishing mechanical and functional intestinal obstruction. Normally, bowel movement cell ranges from 4 to 32 times per minute. Although the clear result is in the right lower quadrant, it is essential to listen to all quadrants to get a comprehensive assessment of bowel activity. Also, by auscultation, evaluate murmurs and diagnose abdominal aortic aneurysm and dissection. So, in the evaluation of surgical abdominal conditions, it is essential to examine and analyze both systemic and paraclinical symptoms. However, these findings must be interpreted in the conjunction with clinical symptoms. For example, Hippocratic phases. In cases of late stage of peritonitis, patient may exhibit a characteristics Hippocratic phases marked by a gout or second eyes appearance. This is a sign of advanced illness and should be assessed alongside clinical symptoms such as diffuse abdominal tenderness and signs of systemic infection. Pale skin. Pallor in patients may indicate significant blood loss or shock in the context of intra-abdominal bleeding. However, the symptoms should be assessed alongside other abdominal symptoms such as abdominal pain, tenderness, or sign of distensions to provide a complete clinical picture and guide accurate diagnosis and treatment. Also, the gait observed in a patient with a surgical abdomen often exhibits a protective gait. This gait involves the patient adopting a bent forward position or folded position, indicating that patient is experiencing significant pain. The protective gait is characterized by forward flexion or warding posture. Next, we talk about the subclinical and surgical abdomen. Usually, there are abdominal X-ray, ultrasound, and CT scan. These imaging modalities can reveal signs such as gas and fluid levels or dilated intestines, which may suggest an intestinal obstruction. However, the clinical picture must align with these findings. Mean we have to look for symptoms such as abdominal pain, vomiting, and distension. If diarrhea is present, we have to consider the possibility of a digestive infection rather than a bowel obstruction. Okay, this is the end of the part 1. Thanks for your watching and see you soon with part 2, the clinical application of surgical abdomen. See ya!